Thank you, Dr. Professor Ali, for the kind invitation. I want to thank Dr. Amir Aseeri, the chairman of the Southern Region chapter of the Saudi Critical Care, for giving me this opportunity to be part of this activity. I'm honored and privileged to be part of this and part of the greater society, the Saudi Society for Critical Care. I'm representing the Southern Regions chapter of the Saudi Critical Care, and we are very glad and honored to present Dr. Emmanuel. He is the clinical microbiologist and chief pathologist in Aseer Central Hospital. And he's gonna give us the microbiologist's point of view regarding the multi-drug-resistant bugs in the COVID pandemic, in the COVID era. I think it's an amazing. I can expect that it's going to be an amazing lecture because it's going to give us that perspective that a lot of us lack, and we are very glad to hear from you, Dr. Emmanuel. The floor is yours.
Good evening, all. As said earlier, my name is Dr. Emmanuel Shubawale, Chief Pathologist and Clinical Microbiologist in Aseer Central Hospital. This evening, I'll be presenting Antibiogram interpretation and MDRO screening updates in intensive care units. Okay. All right. So how is the audio?
It's perfect. Go ahead.
Okay. All right. Okay. So I'll move on to the next slide. Sorry, some technical. How is it? Can you see me clearly now?
We're not seeing. I think we're having the same problem we had before. We're not seeing your slides being shared. Oh, try to share your slides again. Our slideshow again.
Okay.
Yeah, just give it some time.
How about now?
I think it's a bit slow.
How about now?
I think still we're not be able. Try again, please. Just click it once.
Okay. Start over. How about now?
I think we can proceed with the way it is.
Okay. Okay. So declarations, I have no company interest whatsoever linked to the data generated for this presentation. In addition, there are no sponsorship interests from any third party whatsoever. So having done the declaration, this is the outline we'll be following this evening. I'll introduce the topic. We will look at the resistance patterns, comorbidities, recommendations, and I will conclude the topic. Just to be clear, are you still seeing the slides?
Yes, we are seeing. Go ahead, please.
Okay, all right, okay. So the objectives of tonight's presentation are to look at the prevalence of MDROs during the COVID-19 era, and look at the proposed reasons for increasing MDROs, the importance of early detection, how to interact with the clinical microbiologists, and what strategies we can put in place to prevent this scenario. This is just a glossary of terms, ESBLs, meaning extended spectrum beta-lactamases.
I'm sorry, Dr. Emmanuel. Your screen is frozen. We're not seeing your progression. You're not seeing your slides being progressed.
How about now?
Share and share again.
Okay.
I'll share my screen and then maybe. Okay. Try again, please.
Can you see the glossary of terms?
Okay, perfect.
Okay. All right.
Okay.
So we also have VREs, which are becoming more popular these days, the vancomycin-resistant enterococci, carbapenem-resistant enterobacteriaceae, that's CRE. When we say PDR, pan-drug-resistant, resistant to all antibiotics, multidrug-resistant, and extensively drug-resistant. And we shall look in detail at what this entail as we go on. So the development of antimicrobial resistant bacteria is occurring globally, and it is endangering the effectiveness of antimicrobial medications. These are previously been saving several lives, has transformed medicine. Now we are combining this scenario with the novel coronavirus, the SARS-CoV-2, and this represents a double-edged sword. So on one side, you have antimicrobial resistance, and then you have a bug that causes global pandemic. The novel coronavirus disease 2019 was first isolated from biological samples, as we know, in Wuhan, China, in December of 2019. It was identified as a member of the genus, the beta coronavirus, placing it with SARS and MERS in the same category. As a result of this infection, co-infection with COVID-19 and MDR pathogens, in our Central Hospital, we sought to generate data on the prevalent pathogens as well as their resistance profile in this subset of patients. This data will help the microbiologists to profile solutions to clinicians in the management of infections in the ICU, as well as help reduce mortality, which is the end game. And how did we do this? We developed an antibiogram to help us to predict susceptibility patterns or resistance patterns and help in treatment. Now, what's an antibiogram? Joshi et al. Defined an antibiogram as a periodic summary of antimicrobial susceptibilities or resistance of local bacterial isolates that are submitted to the hospital's clinical microbiology laboratory. And as such, the clinical microbiologist or the medical microbiologist plays an important role in formulating this antibiogram. We have different types of antibiograms. Are the slides progressing?
Yes.
We have stratified antibiograms, we have non-stratified antibiograms, and we have cumulative antibiograms. And in the subsequent slides, we'll see what we mean by this. So the antibiogram is an essential resource for institutions to track changes in antimicrobial resistance and to guide empirical antimicrobial therapy. This is before results of antimicrobial sensitivity or resistance are out, so we can predict from previous results. And the cumulative antibiogram is a periodic profile of antimicrobial resistance of various organisms that are isolated from the ICU to track what is happening. So we utilize it to monitor recent antimicrobial patterns in order to guide empirical antimicrobial selection, therapy selection. And what are the components of this cumulative antibiogram? This included the names of the organism, that's one, the number of isolates that were analyzed, the agents the antimicrobial agents that we tested, the percentage of each organism interpreted as susceptible to the listed antimicrobial agents. And this was based on what we call CLSI recommended breakpoints. The CLSI is a body in the United States. There's the Clinical Laboratory Standards Institute that gives us yearly breakpoints for antimicrobial agents. So like I said earlier on, the components of our cumulative antibiogram include the names of the organisms, the number of isolates we analyzed, and all this other data that I mentioned earlier on. So what did we do? We analyzed the data of 85 patients that were infected with COVID-19 who also admitted in our ICU. So the selection criteria are patients who had both COVID-19 and antimicrobial an infection from bacterial bugs. And this was over a 12-month period from January 2021 to December 2021. And so we ascertained the antimicrobial resistance and susceptibility patterns of these microbes that we recovered. And organism identification was done with the following machines. Can we see this slide, the three machines? Is it showing?
Yes.
Okay. So we use the microscan walkaway, the BD Phoenix, and the Vitek 2. This will also enhance and strengthen our level of precision and assurance. We also linked our Antibiogram with a software developed by the WHO, that's the World Health Organization, called WONET. This WONET has selected breakpoints that help us to standardize what we are doing. So we also had guidelines for development of the Antibiogram. And that's that we must include results for antibiotics that we routinely test and that we routinely use also. This is one criteria. And that only the first isolate from a patient, irrespective of the specimen, should be included. So if a patient has had 4 different cultures sent to the lab, it is only the first one that we record. And that the cumulative antibiogram should present only the percentage susceptible and not those which are intermediately susceptible. So we removed the intermediate category and we used it to stratify the antibiogram into outpatient, inpatient, and ICU data. But the ICU data is one we are presenting today. When we say MDR or multi-drug resistant, we mean resistance to 3 or more classes of antimicrobials like ciprofloxacin, augmentin, and gentamicin. When we say XDR, that's extremely drug resistant, we mean susceptible to only 1 or 2 classes of antimicrobial agents. And when we say pan-drug resistant, we mean resistant to all classes of antimicrobial agents. Now, this is the Antibiogram tool that we developed. It's just 1 page, which captures all the data that we need for each patient to make it easy for us to also enter. It includes the months of the year, the biostatistics, the biodata of the patient, the organisms, and the resistance profile. So we use a local antibiogram that provides a profile for us, like I mentioned earlier on, and we built it up month by month, so it was able to become an annual cumulative antibiogram. And the end point of this antibiogram is to help us in antimicrobial stewardship. We shall see in the subsequent slides what we mean by antimicrobial stewardship. So cumulative antibiograms, like I mentioned, they capture the susceptibility or resistance data over a period of time. It could be over 6 months, or it could be over 12 months, or that's annually. So now looking at the data that we generated, over the 12-month period, we sampled 232 ICU patients. But the patients that were infected with COVID over that period that we also sampled were 85. The mean age of our patients was 48.8 years, roughly 49 years, with a median age of 47 years and an age range of 12 to 99 years. So our youngest patient was 12 years old and our oldest patient was 99 years old. So that shows the gender distribution and the age group. The first one shows the age group below 65 and the light blue above 65. The third bar just shows ICU patients versus patients from other wards. So looking at the sample distribution, we found out that most of our samples submitted were urine samples, followed by sputum and endotracheal tube. The interesting finding was also that we found a lot of patients with ventilator-associated pneumonia and urinary tract infections. Other sample sites that we sampled were abscesses, blood culture, aspirates, soft tissue pus, and tracheal secretions. Looking at the comorbidities of our patients, pneumonia and sepsis were the 2 predominant comorbidities that they had, followed by urinary tract infection. We also had a wide range of patients that had urinary trauma and road traffic accidents that also coincidentally were infected with COVID. Some patients with acute kidney injury, chronic kidney disease. So this is the spread. This slide shows the spread of comorbidities of our patients. Now, we also looked at the distribution by month. And the vast majority of our patients came in January and on November, and then the other months are in between. So that shows the distribution by month. Are the slides still showing?
Yes.
Okay, all right. Our prevalent organism was Klebsiella pneumoniae. This was the most troublesome pathogen, and not only troublesome in terms of the infections it causes, but the rates of resistance. We had a high rate of carbapenem-resistant Enterobacteriaceae in these patients, followed by Acinetobacter baumannii and then Staphylococcus aureus. This includes methicillin-resistant Staphylococcus aureus and patients with Proteus mirabilis infections and Enterococci. So we look at resistance phenotypes in the pre-COVID era, before COVID came in. And MRSA and MRSA, that's methicillin-resistant Staph aureus, were our troublesome pathogens. They were quite prevalent, followed by vancomycin-resistant Enterococcus. And then you also had CRE. Let me just go back. But you can see a reversal. You can see the Klebsiella pneumonia now became much more prevalent. So we saw an ascendancy of gram-negative bugs. So you have a patient with COVID-19, there's a high probability that that patient might come down with a gram-negative bug while on admission. This was also a study done on CRE in ICU, in intensive care units by Agrawal et al. In 2016. And you can see that before COVID, in their own facility, non-fermenters and fermenters such as Acinetobacter baumannii were actually much more prevalent than Klebsiella pneumonia among the gram-negative organisms. And if you look at our findings also before COVID, you see we saw a lot of ESBL gram-negative rods before CRA KPCs. Now moving on to the next slide also, looking at multi-drug-resistant UTIs, urinary tract infections in the ICU of this particular ICU in Europe. This, I believe, is somewhere in France. You see that E. coli, that's Escherichia coli, predominated before carbapenemus-resistant Enterococci. So what is happening now is that the multi-drug-resistant bugs, for some reason, are in the ascendancy. This was not the picture before COVID. Look at another study looking at nosocomial infections in the neonatal intensive care unit. This is also in southwestern Saudi Arabia. This is Aba General Hospital. This was done in 2010. Looking at the prevalence of infections in their own particular facility. Sorry, yeah. You see that there's a prevalence of pneumonia and sepsis, which was not uncommon in the ICU. And this is still the prevalent pattern in terms of infections. Another study also looking at antimicrobial resistance rates in an ICU, looking at the etiology and risk factors. They found that gram-negative bugs predominated, and looking at the resistance pattern, the resistance profile, you see that there's a decrease in the susceptibility ratio. Virtually all their bugs was resistant to quinolones, and we use quinolones a lot in our ICUs. So this begs the question: how effective do this class of antibiotics to the prevalent pathogens? Again, in the pre-COVID era, looking at prevalence of multi-drug resistance and XDRs and pan-drug resistant Pseudomonas aeruginosa. This is from a tertiary level ICU in India. Pre-COVID, the picture has not really changed much. 96% resistance rates to ciprofloxacin. So this drug is virtually becoming ineffective in our ICUs. And a medication that we don't really look at very much is aztreonam. Surprisingly, in this particular ICU, they had low rates of resistance to aztreonam. This might be an alternative antibiotic that might be worth considering. But more studies will need to be done to ascertain that. This is another study looking at the prevalence of nosocomial infections in the Saudi Arabian teaching hospital. This was done by Abu Saud a long time ago in 1991, pre-COVID. And you see again, Escherichia coli, Pseudomonas aeruginosa, Staph aureus, Klebsiella pneumonia, which is becoming the troublesome bug, was fourth on the list, followed by other gram-negative organisms. Now, a prospective multi-center study was done in 5 cities in the Kingdom of Saudi Arabia, pre-COVID in 2016, to look at the prevalent organisms causing bloodstream infections. Acinetobacter baumannii, before at the baseline rate was the most prevalent pathogen, and you go down the list before you come to other pathogens. But in this particular study, they had some interventions, and it saw that there was some significant impact in the interventions that they did in reducing collapses. This other study that highlights the epidemiology of healthcare-assisted infections and antimicrobial sensitivity patterns in the Al-Qasim region in northern Saudi Arabia. And you see that over a 4-year period, they had a slight rise in ICU infections and a sharp decline. So it begs the question of what intervention. They had some interventions such as bundling, which they started in 2015, that helped to help in this sharp decline, both in their ICUs, in their neonatal intensive care unit, and their male medical ward. And as we go on in the presentation, we'll look at the effect of bundlings, which we have recommended for our own hospital. Again, looking at prevalence of nosocomial infections in another Saudi Arabian teaching hospital, you see the spread of, you see that the troublesome aspects of infections, again, are the ICU and the small care baby units. Are we together? Dr. Shah, are the slides you showing?
Yes, sir. Go ahead.
All right. Okay. All right. So this just also alludes to the fact that the ICU and the medical wards, these are places where we have this same core troublesome pathogens regarding hospital-acquired infections. At another study that highlighted high antimicrobial resistance rates among gram-negative pathogens in the ICUs. These are the retrospective studies done pre-COVID. Again, Acinetobacter baumannii, Pseudomonas aeruginosa, before Klebsiella pneumoniae and Proteus mirabilis. These are the prevalent pathogens across the ICUs, NICUs, and CCUs before we come across E. coli and other gram-negative rods. So we looked at our resistant markers in our ICUs, and what we found before COVID was that 33% of our gram-negative organisms were ESBL producing, which I mentioned at the beginning, meaning that ceftriaxone will not work for these organisms. Cefotaxime will not work, only meropenem. And then 24.1% CREs, meaning your meropenem will not work, only antimicrobial agents like colistin or ceftazidime avibactam. And then we also compared what we are seeing with our own ESBL profile with ESBL profiles in another ICU. This is an ICU in India. And you can see, look, if you look at the resistance rates here, the lines in blue show resistance rates. You can see that even, susceptibility profile rather, it's only imipenem that gives you a probability of above 95% in terms of efficacy. All other antibiotics below the 95% line. We compared our findings to multidrug-resistant organisms in King Fahd Hospital in Pofuf. We looked at the MDRO rates in their ICUs, and it is alarmingly large. About 68.2% of their organisms are multidrug-resistant organisms, which also is in keeping with our own findings. So apart from the issue of COVID, it's also been shown that high rates of antimicrobial use are also fueling and driving these patterns that we're seeing, such as what we have, looking at these MRSA susceptibility patterns in KKUH in Riyadh. The only good news, the major good news from this study is that vancomycin is virtually 100% effective. But when you look at other antimicrobial agents, such as clindamycin, barely 8%, barely 9%, tetracycline, ciprofloxacin, you see very low rates of susceptibility to MRSA bugs. And we do have a lot of MRSA bugs. So we looked at the percentage of our organisms that were percentage resistance, looking at the gram-negative bugs. You can see that drugs, medications such as amikacin, 61%, medications such as topramycin, 64.5%. So we're losing the battle regarding our aminoglycosides. The only good news from our study is that colistin is the one that they show the least resistance to. That's 10.6%. But we have to also bear in mind that colistin is somewhat nephrotoxic. And this seems to be our last resort, colistin, followed by ceftazidime avibactam and a few other novel antibiotics. Then looking at the gram-positive cocci. In terms of percentage resistance, is also another sad story. Minocycline, almost approaching 100%. Looking at ciprofloxacin, almost 60%. The only reserve antibiotic we have left is vancomycin. And it seems these days that vancomycin-resistant organisms are also on the rise. That's alluding to vancomycin-resistant enterococci. Now, we looked at our resistance markers for the patients across board. 2.4% of our isolates are pan-drug resistant, that's resistant to all antibiotics. 28.9% extremely drug resistant, that's in the COVID-19 subsets. That's to 1 or 2 antibiotics. And 42.2% are multidrug resistant, that's to 3 or more classes of antibiotics. So this shows the enormity of the picture. We also went further to do some genotyping of some of the multidrug resistant bugs. That's the Carbapenemus resistant Enterobacteriaceae, particularly the Klebsiella pneumoniae. And we found that 39, almost 40% of them, produce OXA48. Now, this is good news. Why is it good news? Because we can use ceftazidime avibactam in management of CRE infections. We've also seen NDM in some of our patients, possibly from travel to other countries. This was not the prevalent marker before. We also see VIM, KPCs. These are genes that are expressed by these multidrug resistant organisms. Again, this was shortly before COVID started in 2019/2020. We've been seeing a slight rise in CREs in Saudi Arabia, especially in Klebsiella pneumoniae, the prevalent pathogen. And in Saudi Arabia, NDM, that's the new Delhi metallobeta-lactamase, prevalent in India, and the OXA48 were the ones prevalent in this particular study. So Klebsiella pneumoniae, E. coli, and Enterobacter aerogenes are the prevalent bugs. But we've started seeing these pictures in other gram-negative bugs also. And so this is the tool that we used to do the genotyping, the GeneXpert 16. We have a 16 module. Within 1 hour, we are able to identify the gene once we have isolated the organism. And it has really helped and revolutionized the management of the CRE pathogens. Because once we're able to get a particular genotype, we inform the pharmacy and they make ceftazidime avibactam available for the management of the patient. So looking at Klebsiella pneumoniae and COVID patients in our own facility, looking at resistance to antimicrobials. If you look at the deep blue line, you can see these are COVID patients versus non-COVID patients. And you can see clearly, and this is the crux, this is the kernel of the matter today. This just shows the impact of COVID. Once a patient is infected with COVID and a bug, you have this particular scenario across board. Even down to cholesterol, where you have an average of 39% being resistant, and then 28% for non-COVID patients. We extrapolated our data further to also look at if we will see this particular pattern, if we break it down organism by organism. In Acinetobacter baumannii, which is a problematic pathogen in the ICU, you can see the effect of COVID again. The patient is co-infected with COVID and Acinetobacter baumannii, the organism just somehow behaves differently. The antimicrobial resistance rates just shoot up. Again, Pseudomonas aeruginosa, COVID versus non-COVID. Again, you see the same pattern that we've seen in the previous slides. You take note again, like I mentioned about aminoglycosides, gentamicin, 61% versus 26%, looking at both COVID and non-COVID patients.
Sorry, Dr. Emmanuel, is this data from Aseer or from like international?
This is from Aseer only. Okay. This is Aseer Hospital. But I am juxtaposing and comparing some of the slides with data from other hospitals. Are the slides still showing?
Yes, it's showing.
Okay. Yeah. Okay. So now also looking at Staphylococcus aureus, again, we see a similar pattern. The only good news we have from our ICU is that there is no vancomycin-resistant Staph aureus. And to the best of my knowledge, it's virtually non-existent in Saudi Arabia. So it also follows what we are seeing at the national level. But again, looking at the percentage of resistance in COVID versus non-COVID patients, it's a worrisome picture. And this might also allude to the high mortality rates that we are seeing in COVID patients who are in the ICU. Are they dying from COVID, or are they dying from multidrug-resistant organisms, or a combination of both? In my opinion, I think it's a combination of both. Again, looking at enterococcal species, the only exception to the rule that we've been seeing so far is high-level aminoglycoside amikacin, high-level streptomycin. These are the only two antibiotics so far that are not following this model of COVID versus non-COVID. But again, you go across board and you see that once a patient is infected with COVID, AMR shoots up. Now, apart from doing that, we also sought to find out what are the MICs of some of the antimicrobial agents in our patient subset, in this 85 patients with COVID-19. So talking about the MIC, that's just the minimum inhibitory constitution, the minimum amount of the antibiotic that will stop growth of the bacteria. We selected colistin, and our average, our prevalent MIC was 2.0 micrograms per mil. Now, what does this mean? If you have an MIC that is less than 2, you will say that the bug is sensitive to colistin. If you have an MIC that is greater than 4, we will say it's resistant. If it's between 2 and 4, intermediate. But you can see that this is where the vast majority of our patients are hovering around. So if we're not careful, we'll begin to lose colistin also to gram-negative bugs. Again, looking at this is Klebsiella versus colistin MIC. The previous one was COVID-19, but we broke it down to Klebsiella versus colistin MIC. So our MIC is between 1 and 2. This is where most of the MICs fall for most of the patients. For most of the patients in the ICU. So again, we're gradually shifting towards the right. If we have a shift to the right, we start seeing MICs of 32, 16, 18, 4. It's not good news. Not good news for us. We also looked at meropenem. Again, you see this, most of them are moving towards 8. Tigecycline, another reserve antibiotic. Fortunately for us, we seem to have some good news with tigecycline, but tigecycline doesn't seem to do very well for patients with bloodstream infections. So it seems not to do very, very well. The response rate to tigecycline is not so high, despite the fact that we have relatively low MICs. Looking at vancomycin MICs also, if you have an MIC below 2, it's susceptible. The ones you see from 4 and above, these are in our vancomycin-resistant enterococci, which I said we are beginning to see seem to be on the increase. But so far, so good. Most of the MICs fall between 0.5 and 2, which is a little bit heartwarming. So what do we do in the microbiology lab? We just simply help in interpreting these antibiograms for the ICU to help to identify the microorganisms to species level, in separating them into susceptible, intermediate, or resistance, to define the common phenotypes. Sometimes we see some unusual phenotypes, or what we call some impossible phenotypes that we should not see, and we alert the ICU to them, to such phenotypes. We also help in deducing what we call biochemical mechanisms of resistance, and how important those resistance mechanisms are, like the ESBL I talked about, the CREs, the MRSAs, the VREs. So, impact of antimicrobial resistance post-COVID-19. After the pandemic of coronavirus 2019, antimicrobial resistance has become an increasingly challenging complex that needs to be addressed during and after this corona pandemic. This chart just shows mortality due to antimicrobial resistance by the year 2050. and it's not good news, showing the attributable mortality due to antimicrobial resistance. And if you look at the Middle East and Africa, looking at close to 5 million deaths expected by 2050. So if we're not careful, if we're not able to curb this trend of MDRO, there's a looming disaster waiting. Why do I use the word looming disaster? Because in the last 40 years, fewer and fewer new classes of antimicrobials have been developed by pharmaceutical companies. So why are we losing this war against microbes? Number one is the overprescribing of antibiotics by physicians in the absence of a clear diagnosis. We also have a high doubling rate of bugs. These bugs multiply within 20 to 30 minutes, while it takes humans 20 to 30 years to replicate. And also movement of people across the globe, even during this pandemic. Other factors that are also aiding the pathogens in winning this war, the fact that we're not doing much research, there doesn't seem to be much commitment. The quality of the drugs sometimes are suspect. We don't rationally use drugs. There's weak infection control, and we're not doing enough surveillance of resistant pathogens. Are the slides still showing?
Yes, sir, it's showing. Go ahead.
So other reasons also favoring AMR, prescribing long courses of antibiotics. Once there's no need to continue, we should stop. Are we dosing as much as we should? Are we skipping doses? Are we using antibiotics for the right duration? Do we adhere to guidelines? We have guidelines, but are we adhering to them? Are we also being guided by susceptibility patterns? And do we have enough data on such patterns? And that leads me to the role of antimicrobial stewardship, where the microbiologist team plays a big role. Antimicrobial stewardship just seeks to work towards antimicrobial control. And it works with the infectious disease specialist, infection control, microbiology, the pulmonary team or the intensivist, the nursing team, the surgical infection experts or surgeons, the OR personnel, the clinical pharmacist, and the hospital administration. They all have a role to play in antimicrobial stewardship. And the 8 goals that we seek to promote is to educate the healthcare workers on how to use antibiotics, working towards limiting antimicrobial resistance, also decreasing adverse events due to antibiotics, helping to reduce healthcare costs, reducing inappropriate antibiotics use. There must be a strong compelling indication to use antibiotics, helping to improve patient outcomes, and also increasing adherence to guidelines, national guidelines. So what's the role of the microbiologist in antimicrobial stewardship? Again, as I mentioned, to help reduce antimicrobial resistance rates by giving advice, to help reduce the adverse effects of antimicrobials, also to help reduce overall mortality due to infections, to help in reducing costs, and to help improve patient outcomes. Also in pre-authorization of antimicrobial prescription when we are called upon, to also prospectively evaluate new antimicrobials whenever they come, educate the ICU on antimicrobials, also help in reducing overall antibiotic use, because when you increase antibiotic use, you increase selection pressure, and it is this selection pressure that selects resistant bugs. To help formulate local hospital antibiotic guidelines, to help formulate local hospital antibiotic policies. I'll pause here. What do we mean by guidelines and policies? The policy says a consultant can prescribe this antibiotic, a resident can prescribe this antibiotic, a medical officer can prescribe this antibiotic. These are policies. But guidelines, if you have ventilator-associated pneumonia, give the patient ceftazidime plus aztreonam if it is within 4 days. If it is above 4 days, add vancomycin. Those are guidelines. So it's the role of the microbiologist to help in formulating these guidelines. We also work in phone consultations with ICU physicians. We're just a phone call away. Also in auto-stop policies, you cannot prescribe this antibiotic for more than 14 days. After 14 days, you must stop. After 7 days, you must stop. Also periodic antibiotic reviews and audits, which is what we're doing today. to help in therapeutic drug monitoring, because some of these medications are nephrotoxic, like aminoglycosides. Also help in policy on switching from intravenous to oral medications as the patient improves, and electronic other systems. Also, management of febrile neutropenia and other aspects of patient care. And also determine resistance rates, like I've been mentioning today, the MRSAs, ESBL, CREs, VRE, and also in helping strategies to reduce resistance rates. So we also help in the area of hospital-acquired infection prevention, as is happening in the ICU. And that it has to do with infrastructure, how our ICU is designed in terms of patient exit and entrance, relatives exit and entrance, communication. If there's an outbreak, how do we investigate this outbreak and how do we communicate the findings? Surveillance is so important. Looking at monitoring antimicrobial resistance, working with hand hygiene. These are all core elements. And so in Aseer Central Hospital, we have promoted or we have suggested bundles to help in reducing hospital-acquired infections in the ICU. The bundles are just a set or a system of procedures that, when done together, have been shown to improve patient outcomes. And these have been standardized and shown to be effective. We have different types of bundles. We have hand hygiene bundles, central line bundles, bundles for sepsis, which are quite popularly known as the sepsis 6, ventilator bundles to help prevent ventilator-associated pneumonia, urinary catheter bundles, and bundles for clostridium difficile diarrhea to prevent them from happening. Are the slides still showing?
It is.
Okay. And then we've also been, like I mentioned, these bundles have been shown in different settings to improve patient outcomes. This was a study done looking at the effect of bundling on catheter-associated urinary tract infections. When they introduced it, before the bundle, they had high rates of catheter-associated UTIs, but as they improved, as they implemented the bundles, their numbers of CAUTI or CAUTI reduced drastically. So it has been shown and proven in other places to work, and this might also be a life-saving strategy for our patients in our various hospitals across the kingdom. So coming to the end of my presentation, the rates of antimicrobial resistance are continually increasing in this COVID-19 era. It is the responsibility of all members of the ICU team to drive down the rates of antimicrobial resistance by collaborating effectively. Thank you for your time. Thank you for listening. I will now entertain questions or any comments or additions. Over to you, Dr.
Thank you, Dr. Thank you, Dr. Emmanuel. As expected, it was a very lovely lecture. I really enjoyed it. We'll leave the floor for any questions. Prof. Ali, if you want to comment before the questions come up.
Thank you very much, Dr. Shahir and Dr. Emmanuel. It was really an excellent, eye-opening talk about the burden that we have and we are facing. You can go through the questions and we'll leave the, if the audience have any questions, we can go through. I don't know whether there are a written one on the Q&A.
I will follow it up. If there is any, I will let you know.
Yeah.
On them, I think we have one hand up. Dr. Abdurrahman. Go ahead, please. Dr. Abdurrahman Al-Almai. Unmute yourself, please.
Hi, everyone, and thank you, Dr. Emmanuel, for this nice presentation. I'm wondering or curious about why they, I know it's a debate question, but I'm not sure what's happening for our habits. It's why they change the resistance of pathogen during COVID era from the pre-COVID era. I mean, I see the patient now, Klebsiella pneumoniae, they have more resistance during the COVID. So I'm wondering, is that because we are more protected for ourselves and taking PPE as precaution for every patient we go in, or it's different from the culture we requested every time we are dealing with the COVID ARDS, so not requested too much culture, sputum culture, and others. So is there any explanation from your side as intensivist or as also Dr. Emmanuel from microbiologist? Thank you.
Thank you for your question. Over the past 2 years or 3 years now, the rates of antimicrobial use has increased drastically. You know, some of these COVID patients also have coexisting infections, and there seems to be some suppression of their immunity. And this also predisposes them to infections in the ICU. You have a patient on ventilator, it's just a question of time, in most cases, before the patient comes down with ventilator-associated pneumonia. You have a patient that has a central line in place. This central line would act as a nidus, as a portal for entry of organisms. You have a patient that has a catheter in place. You have a patient that has undergone ECMO. Some patients have 3, 4, 5 different tubes running through them, not only in the ICU, but also in the CCU. So you see, adding all of this together with multiple interventions, multiple personnel, multiple access to different personnel, different teams coming in, it's just a question of time before one bug. And if you have a multi-drug-resistant pathogen in your hospital, if hand hygiene, and I suspect that the 3 drivers, the possible 3 drivers, the high rates of antimicrobial use, hand hygiene, and a lot of procedures in a subset of patients that are relatively immunosuppressed will act as a culture, or like a soup pot for these organisms to thrive. And when you have just few antibiotics, colistin, tigecycline, ceftazidime, avibactam, what can you do? So the key thing is to prevent these infections from happening in the first place.
Dr. Emmanuel,
if I've gotten across.
It's a continuation of Dr. Abdurrahman's question, actually. The question was coming through my mind during your presentation, which is the COVID pandemic is an exceptional situation. I mean, I understand hand hygiene, bundles, and all that sort of stuff, but keep in mind that the restraint that have been done over the healthcare providers is not as easy being done as said. That's first comment rather than a question. But my question is, do you think that is it the COVID itself and the immunocompromised patient or the viremia or that led to the high endemic of MDROs, or do you think is it the overuse of antibiotics? Intensivists were afraid from this new virus. Nobody knows what it is, so we are over prescribing antibiotics because we don't know what we are dealing with. The other issue, do you think that I think we used so much steroids in the COVID patients as compared to the previous ARDS patients? I mean, we were giving them so much. At some point, I think DEXA was reaching up to 20 milligrams. Some of the severe ARDS patients. The question is directed to you from a microbiologist point of view, and I think also some of our senior intensivists, Prof. Ali, and anybody wants to have a comment and regarding this point.
Okay, thank you for your question. I think it's a combination of several factors, because you look at the non-COVID patients and they seem to be doing a little bit better in terms of their response to antibiotics. So I think I wouldn't stick my neck out and say it's one particular factor, but I think it's a multifactorial thing. We are still collecting data. The next phase of our data is we want to look at the different age populations, those below 65 and those above 65, and see their response to antimicrobials and also their resistance patterns. That might also help to give a clue, and also to gather more data on comorbidities and see if that is also affecting. So if you recall, I had a slide that showed different comorbidities that some of these COVID patients had. So I think I would still stick to the position that it's a multifactorial thing. Over to you. Yeah.
Prof. Ali, can we hear your point of view, please?
I totally agree with Dr. Emmanuel about the why we saw a lot of or let us say burden of this antimicrobial resistant during this period. It's a multifactorial. We couldn't focus to one specific reason, but I think if we clump them together, as you mentioned, Dr. Shahar, steroid use in COVID is more than others for sure. IL-6 inhibitors also have been used more, and it's part of the therapy and protocol for those patients. One other point, those patients, when they get intubated, they stay in ventilator for longer time. Like they stay longer, and as we know, patient when they stay more ICU stay, the chance of getting colonized and infected with these MDR bugs is increasing. Second thing, during the COVID surge or the pandemic, the supply chain have been affected for sure. Dr. Emmanuel, he alluded about using bundles effectively, and it is well shown across the literature, it's decreased the infection rate and mortality as well. But when we have a lot of patients compared to the staff, more patients, more than usual, and the supplies, and as you notice everywhere in the world, and we have seen in some European countries, patients, they are on the corridors. They don't have even bed to stay and to be properly managed. And you can imagine how the infection precautions and adherence to the bundles that we alluded to will be followed. That's second. Still, also as you mentioned, the overuse of antibiotics. It's still I think it's play a role, and when the disease starts, people they were giving heavy gun antibiotics in the first week, where there is no chance at that point there will be a bacterial infection.
In my hospital, Dr. Ali, sorry to interrupt you. In my hospital, no patient was admitted to the ICU as COVID did not receive meropenem.
And I think it's
I think it's too much.
And it is promoting the CRE, and probably apart from the CRE rise that Dr. Emmanuel showed in his slides, is probably the overuse of carbapenems. Yes. We are now like studying this CRE, and Dr. Emmanuel, he showed one of his slides, the gene resistance, and we are just finalizing one manuscript in collaboration with our microbiology team, getting those who had CRE, what's the resistant pattern, what is the gene resistance. At the same time, among the data, we compare COVID-19 with non-COVID-19 patients, and we found two major predictors with statistically significant toward increasing the risk. One of them is age more than 65. Yeah. And second thing was presence of COVID-19 as a causative agent for ICU admission. Their mortality is totally different from the non-COVID patient who came to ICU during the, and they have Klebsiella as well. So all of them, they are CREs, but those who are aged more than 65 and those who have COVID-19, their mortality is statistically clear different, and to the, unfortunately, the worst side compared to the non-COVID-19 patients. Our colleagues on the group who they want to share their experience, they are welcome. Just unmute yourself and you can share with us.
Until somebody shares their experience, I have a question, Dr. Emmanuel. It's a more of a technical question. How do we do the gene classification of the KPCs or the CRE? Okay. Do we have to isolate the bug first to identify that this is KPC or CRE, and then we analyze the gene as OXA45 for New Delhi, or you can go straight from the sample straight to the genetic testing?
Actually, you can, from parectal swabs, directly take a parental swab and put in the machine, and it can screen for us and give us the gene. That's actually possible. But if you have a high index of suspicion, you can just take a parental swab. The parental swab is the recommended actually for screening. Just as we do MRSA screening, we can do CRE screening with parental swabs and put in the machine. But the problem is this: the yield is very low. What do you mean by the yield is low? You may have to sample up to 20 patients or 30 patients before you have one positive gene identification. So what we do presently is we take the bacteria, the bulk from the plate that has been cultured, from the urine, the sputum, the blood, and we put in the machine, and then we can, if it's multi-drug antimicrobial resistance is on the high side, we put in the machine and it gives us the gene. That is more cost effective because the kit is expensive. Are you with me so far?
I am. It's just. So I understand your point from a screening point of view for a stable patient who is referring from another hospital. Yeah. But for me as an intensivist in the ICU, patient is intubated and he's not responding to my, say, my meropenem or my tazocin. And I'm thinking, oh, the neighboring patient, he has KPC, and now should I send the tracheal aspirate for another culture that is going to take 3-4 days? That is there a rule for a rectal swab at this patient who's critically ill, intubated?
Yeah, the rule is that there must be a risk factor. The risk factor basically is exposure to carbapenems. If the patient has been exposed to carbapenems, and the patient is not responding, that's a candidate for screening. Then we can take such samples and analyze in the laboratory. Rectal swab.
And you said the sensitivity is very low. You said 1 in every 20.
Yeah, because a lot of the patients do not fit into the criteria. That's the reason why the sensitivity is low. It's a lot of the patients don't fit into the criteria, and we just find out that we waste a lot of the kits.
Okay,
but there has to be a compelling reason. Yeah.
For the OXA 45, we can go with the Ceftaz Avi. What about the what about the other genetic phenotypes?
The other ones, we have what we call the XMIT guidelines. The Europeans have devised guidelines for the other ones, and they are just trial and error. What do I mean? They give colistin plus meropenem plus tigecycline in high doses, or colistin plus meropenem, or colistin plus tigecycline. Okay, but whatever you have must include colistin. And so they give it as supramaximal doses at risk of nephrotoxicity, like I mentioned earlier. Yeah.
Fair enough. I want to give more to the audience. Please go ahead, Dr. Hassan Mashbari. Unmute yourself and go ahead, sir. Dr. Hassan. Unmute yourself, please.
All right, thank you very much for having me. Thank you, Dr. Manuel, for the amazing talk. It's scary, actually, to see all of that. One question about the practical, practical wise. We have the data. I mean, what has been done, let's say, on a regional level? I mean, all these studies are done in Aseer. It's very interesting. But I mean, do we have something, on a regional wise kind of studies or initiatives to take from there, especially now? It's a very unfortunate, now we are getting this third, and I think I heard in the news there is a new another one after Omicron is happening. From regional standpoint, I mean, where are we to go from now? I mean, what has been as an initiative, trials, multi-center trials, studies to turn this into more policy related, protocols related, or where are we going from here? I mean, it's an interesting and amazing, and only those who attended this will know about that. But I'm just trying from practicality, where we can take this from here.
Okay.
Thank you very much.
Thank you very much, Dr. Hassan, for your question. We have something called the GLASS study. That's a global antimicrobial surveillance study. And CREs and other MDROs are part of what we are analyzing. These are sent to Riyadh every year. At the end of December, we send such data to Riyadh. We're still waiting for RIA to get back to us and give us their findings. But in the interim, we're also looking at collaborating with other centers in the southern region, so that at the level of the directorate, we can present our findings. And then, but so far so good. At the regional level, it's only Dr. Bashabshi I know that is spearheading some of this. But in terms of coordination, I think we need to work with other hospitals. And that has not been done so far. That's the answer to your question. So the answer is, we have not done much at the level of the regional, yes. Yeah, Dr. Hassan.
After this meeting, maybe hoping that this could spark more further collaboration, inshallah.
Exactly.
Any other questions or experiences or comments, either from the region or from the rest of the kingdom? Dr. Ahmed Al-Madi, please go ahead, sir. Unmute yourself, sir, please.
Assalamu alaikum.
Alaikum salam.
Thank you for the wonderful talk. I have one question. Does colistin nebulization increase the risk of MDRO in the patient or not? Colistin nebulization. Thank you.
Yes, exposure to colistin, if not done properly, can select out some resistant pathogens. And why do I say this? We also have data on colistin-resistant organisms, Acinetobacter baumannii, Klebsiella pneumoniae. These two particular troublesome bugs. And when we go through the case notes, we go through the case files, these are patients that have been exposed to colistins, or patients close to them have been exposed to colistin. For example, a patient in bed 18 has a CRO, and then we see maybe 2, 3, 4 days down the line, the same CRO spread in 2 or 3 other beds close to that patient. So yes, the exposure to colistins, if not used properly, can predispose to colistin-resistant organisms. Dr. Ahmed.
I have a question until further hands are raised. To you as a microbiologist and to the rest of our senior intensivists, do you think that there is an ignorance bias in the form of that certain antibiotics are more familiar to the intensivist or the prescriber? Like, for example, myself, I've never prescribed azetrinium. I don't even know how to pronounce it. So do you think that daptomycin, azetrinium, those certain antibiotics that is less likely used or prescribed, and more in favor of meropenem, tazocin, either because of ignorance, either because of the company reps are more active? Do you think this plays a role into certain multi-drug-resistant organisms?
Thank you very much for your question. I think this problem started with ceftriaxone. The drug reps were pushing ceftriaxone. Ceftriaxone was touted as a wonder drug, a cure-all. And where's ceftriaxone today? Nobody talks about it. And it's the same pattern. Meropenem came, imipenem came. And meropenem is gradually becoming somewhat ineffective. We did a study and we looked at how familiar family physicians are with antimicrobial medications, not here, somewhere else. And we found out that they have a bias. There's some bias towards certain antimicrobial agents because they've used it in social patients and it worked. The way to eradicate this bias is to promote guidelines. That's number one. If we have guidelines will help you to be more flexible. People think guidelines will make you streamlined, but no. A guideline will say for pneumonia, do this. UTI, do this. Sepsis, do this. And then if it seems not to be working, involve the infectious disease specialist, involve the microbiologist. And because we live in a sea of antimicrobial agents. For example, Cinecid, quinifepristine, dalfopristine. Nobody uses it, but it's there, it's available in our pharmacies, and it's effective to some extent. Some of our enterococcus, a simple dose of ampicillin will take care of it. Nitrofurantoin is another antimicrobial medication, very good for urinary tract infections. Even in the ICU, if a patient can, even in the hospital, if a patient can take orally, maybe not in the ICU. Nitrofurantoin, very good for enterococcus. So if we collaborate more with the physicians in the laboratory and with the ID specialists, we can actually spread the antimicrobial arsenal. If we spread it, then we can retard or slow down the rates of resistance. Over to you.
Yeah, Dr. Shahar, I can add one comment. Presence of ID team in the ICU, hand to hand with the intensivist, will play a very good major role in decreasing the antimicrobial resistance for sure. It will be very nice if we have multidisciplinary team, intensivist, ID team, as well as the microbiology, and really we are happy to have Dr. Emmanuel with us, and we are happy when we saw him in the ICU, and he came multiple times, doing some time environmental screening and even sampling, and there is an event or incident 3 days back. We had a patient who had a necrotizing fasciitis, and there was suspicion of some growth. He came himself and he took the sample from the patient after 3 days being in ICU, and we thank him for that. And it will be, we were happy when we have such a teamwork caring for our patient.
Thank you, Prof. Any further question or comments from the audience? What do you think, Prof? Do you have any remarks, or shall we conclude?
No, I think we can conclude.
I'm very grateful to you, Professor, for the kind invitation. Dr. Amir Aseeri, to the Southern Region Coalition of the Critical Care Chapter, Southern Regions, and the intensivists in the region. Dr. Emmanuel, the Golden Star of tonight, thank you so much. You enlightened our minds a lot, significantly. I learned a lot, I hope, as well as the rest of the audience. Thank you so much. We're hoping that we will learn, we'll take this back home. And as Dr. Hassan Mashbari, we can spread this across the regions and hopefully across the kingdom to have further collaboration regarding this project to make it multi-centric. Thank you so much. Very grateful, and have a good night.
Good night. Thank you.
Prof. Ali, you have any further final comments?
Thank you very much all. Thank you, Dr. Emmanuel, Dr. Shahar, for a wonderful night.
Thank you.
Thank you so much.
Thank you so much.